So we welcome Dr. Pat Lau Patanagasem from Khon University for the topic of highly comminuted patellar fractures, exploring options beyond classic fixation. Dr. Pat, please.
Hello, good morning, Chairman, Co-Chairman, and our audience. My name is Dr. Pat Lau Patanagasem from Khon University. So, patellar, as we all know, patellar is the largest sesamoid bone in the body. Its superior 3/4 is covered by articular cartilage, while inferior 1/4 is devoid of cartilage. Patellar fracture is quite rare. It accounts for just only 1% of all fractures. This tiny bone can increase quadriceps strength by 30 to 50% and needed to withstand the load up to 3,000 Newton. The most important blood supply comes from the inferior pole of the patella, especially from the medial part. So whenever we need to evert the patella, I recommend you to go from the lateral. Now, the tension band wiring is a gold standard to treat a simple patellar fracture by converting the tensile force into the compressive force at the fracture site, especially the articular area. However, this technique requires perfect bony contact to prevent the fracture displacement. With more complex patellar fracture, tension band wiring is possible but difficult. The treatment for simple patellar fracture you can do either by tension band wiring, screw, or even plating. But for comminuted patellar fracture can be divided into patellar body and inferior pole patellar fractures. The treatment goal for comminuted patellar body fracture is to restore the articular patellofemoral weight bearing surface, to restore the continuity of the extensor mechanism, and lastly to achieve stable fixation to facilitate early range of motion. The treatment options include combination of surcharge wiring or tension band wiring with or without screw, or to do with it by plating. The treatment strategy firstly is to convert complex C fractures into A or C1 by using mini screw or suture reduction. And second is addressing the articular cartilage by using lateral patellar approach with everting patella, or by digital palpation, or using facet view in the X-ray. Lastly is to achieve stable fixation. In year 1981, Bosman classified comminuted patellar fracture into 3 types, and then later reclassified by Yusan et al. By using CT-based study into 3 groups. First is transverse fracture with comminution, which may combine with the lower pole comminution or the upper pole. This type accounts for about 50% of all patellar fractures. Next is stellate fracture, which generally not or slightly displacement. This type accounts for about 30%. And lastly is displaced comminuted fracture, which accounts for 15% of the case. So there is another study by CJW from Korea, which focus on the fracture pattern found in comminuted patellar fracture. You can see that the incidence of the primary and secondary horizontal fracture line is dominate the coronal fracture map, which is about 95 and 85% respectively. And the vertical fracture line that can create the satellite fragment. The satellite fragment is the small fragment on the lateral on or the medial side of the patella. And also emphasize about the coronal split fractures, the blue line. Okay, the coronal split fracture which can be found in most of the case. This coronal split fragment highlight the difficulty and the risk involved in articular reduction, which can be divided into articular and impacted type. For treatment in this type fracture, the lateral parallel patellar approach with everting patella is recommended. In order to do the surcharge wiring or tension band wiring, we recommend to use stronger material like cable or fiber wire, and using cannulated screw instead of the KY to strengthen the fixation. In case of non-displaced fracture, you can do by percutaneous technique that may help to protect the tissue envelope. And by attempting to catch more bone, you can do by the modified surcharge wire technique, like in the picture. There are many proposed technique now today for treatment of the comminuted patellar fracture. For example, the double tension band wiring technique by Dr. Yogesh from India, or double circlage wiring technique from Dr. Gao. Since the tension band wiring technique doesn't work very well in the comminuted patellar fracture, therefore the paradigm of the treatment is shifted from dynamic compression into neutralizing and buttressing with the plate. Thanks for the hard work from the AO group that they designed the fantastic snowflake design with the bendable arm that you can bend and cut to fit the fractures, and also provide the longitudinal screw or the pole screw, this one, this one, that can purchase from the distal to the proximal part. It comes with the two design plate, the anterior plate and the lateral limb patellar plate. There are many plates available nowadays, but generally can be classified into mesh type, hook type, and basket type. Some can be in combination like mesh plate with the basket or the basket plate with the hook design. There is the systematic review and meta-analysis about the plate fixation in the comminuted patellar fracture. It concludes that the basket plate was more commonly used for the inferior pole, while the mesh plate were suitable for intra-articular fractures. The overall plating was associated with better outcome and fewer complications. And there is another review that also confirmed that the OIF with plating is safe surgical option for the comminuted patellar fractures. Summarize of the key finding for patellar plate is it can provide better stability and rotational force. It can withstand higher load when compared with the tension band wiring technique. The plating is very strong reduction tools from up to 5,000 cycles. It can minimize the interfragmentary movement to less than 2 millimeters. The factor-like plate contour, screw placement, and locking mechanism are significantly impact the biomechanic performance. The anterior patellar plating is not only fixation of multiple fragments, but now it can also convert the anterior tensile force into compressive force at the axial site like the tension band. The multi-planar screw fixation, especially the pole screw with the orthogonal construct, allow better control of the fragment when compared with the tension band wiring and the lateral plate. The inferior pole patellar fractures. The inferior pole patellar fracture usually caused by avulsion of the patellar tendon, which account for 5 to 20% of all patellar fracture. The highlight in this fracture is it is usually comminuted. It can be divided into the fixable and unfixable type. The benefit of OIF is you can achieve the bone-to-bone healing and can avoid the patellar baha. However, OIF in this area is technically demanding due to limit of bone and soft tissue remaining. Therefore, the failure of the fixation is possible. Why should we avoid patellar baha? Because it can decrease lever arm of the extensor mechanism and can cause anterior knee pain and increase energy expenditure, or even can cause iatrogenic rupture of the patellar tendon and quadriceps tendon. In the fixable case, you can do either by limb plate, mesh plate, vertical wiring, transosseous suture, or suture anchor. My preferred technique is to use vertical wiring, which proposed by Dr. Song. The idea of this technique is to pass the wire in order to wrap around the comminuted fragment in the vertical direction to resist the quadriceps force. The location to pass the wire is the junction area between the articular and non-articular area. With this technique, you can combine with the other technique like basket plate fixation, transosseous suture, and screw fixation. In such case that stability is questioned, you can combine with a patellotibial fixation like this. In case of that irreparable, partial patellectomy is an alternative good option. However, we don't recommend to excessive bone removal because it can cause iatrogenic patellar baha. Many studies nowadays have shown that the patellar baha were associated with the poorer outcome. The case example is 40 years old male with a motor vehicle injury. You can see comminuted patellar fracture at the lower pole. My technical plan is to do the OIF by the vertical wiring and adjunct with the transosseous suture. We start with the making the small bone tunnel, then passing the small wire in the vertical direction. I recommend to twist the wire first in order to reduce the fragment together, and then afterward we tie the knot like this. And lastly, don't forget to close the retinaculum. It can adjunct or strengthening your fixation. You can see that after the fixation, the range of motion is quite well. And all the post-op X-ray, we can reduce all the fragment back together. And next is 60 years old male. This case is a little bit quite old, a long period of time, and there's some infection afterwards, so some of the bone loss. You can see severe comminution and with the patellar osteoporosis. In this case, I use the tension band wiring and the rim plate in order to stick all the fragment back together. And you can see that after the fixation can like acceptable reduction and quite well range of motion. It's not that good because some of the bone lost already. Okay, thank you for your attention.
Thank you, Dr. Pat, for that valuable insights.